lockdown. We're all safe at home, and we're very happy to have you back today in the Zoom meeting. So, good evening, everyone. So today I'm very happy to welcome the world-renowned LASIK cataract and corneal surgeon, Dr. Arun C. Gulani, the founding director and chief surgeon of Gulani Vision Institute, Jacksonville, Florida. Thank you so much, Dr. Gulani, for accepting our invitation to join us virtually for this meeting. And I still remember 2 years back in Arvind Pondicherry, where you so passionately taught us about the corneoplastics, the principles and the 5S algorithm. And I'm sure everyone is going to appreciate how good a teacher you are. And today's topic, especially on pterygium surgeries, I'm sure it will be more appealing for many ophthalmologists because it is not refined to the cornea specialist, especially in India. We'll have a totally new outlook on how to approach a pterygium surgery, more like a refractive surgery. And thank you once again, doctor. Over to you.
First of all, thank you so much for the invite. I have wonderful memories, actually. 2017, when I was speaking at your institute, it was an amazing experience. So thank you, Dr. Venkatesh, and all of you. I still remember lots of you. So we'll go through my concepts of pterygium surgery and the topics that we'll review. It's actually dividing into 3 sections. Each section actually is a 4-hour instructional course, but we'll complete all of it with enough time for questions, all right? So I'll have a share screen right now. Let me know if you can see everything. Can you see?
We are not seeing the screen yet, sir. Can you share your screen now?
Just a minute, here we go. Oh, this is the YouTube one on the side then. All right. Can you see now?
Not it, doctor?
Not yet?
Yeah. Yes, we're able to see.
Now?
Yes, you can go ahead.
Okay, lovely. So we'll start talking about pterygium. Obviously, I know a lot of you here, and I do know all of you are wonderful surgeons. So my concept of teaching always takes you into concepts, which is how to plan, and outcomes, which is the most important thing we must plan, and then surgery just happens. So throughout this talk, I'm going to talk about what my desires are, what's in my mind when I'm operating. And really the concept is, I don't want you to think about driving, I want you to think about the destination. And make the drive a fun, keep the music loud, have fun in a nice car, look at the scenery. That's the concept of surgery to me. Do not get so involved in changing the gears and all that stuff that you lose the scenery and the destination. So particular to my heart, pterygium surgeries now, 21 years with this technique that I've done, white papers and publication, but the whole point here is to raise it to a cosmetic level. Cosmetic level for following reasons. I'll give you an analogy of refractive surgery in this all the time, which is patient requests, which is very important, that drives us, and then expectations and your own satisfaction. So first, as I said, wonderful memories of being at your institute, and this lovely gift that you gave me. I still have it adorning, as you can see in my living room right there, which is right here where I'm sitting right now. So it's a real pleasure. This is a book where I've shared my lifetime's work on pterygium. It's by Theme Publishers, no financial interest. You can go online, Amazon.com, etc., and get it. And I'm going to go through all the things that I've written here with some wonderful co-authors. First and foremost, I want you to look at this picture and understand that these are today's patients. They want the best, they expect the best, and you must also live up to that expectation. So this is today's most important slide. Of course, this is my patient, Tracy. All of them absolutely want to look great. To me, there's no such thing as a small problem. If the patient is complaining, it's a problem. We should know how to fix it. So these are actually patients of Pinguecula, if you can imagine, not pterygium. The small little thing that many doctors say, don't worry about it, take the drops, don't be vain. It's not vanity. These patients actually are visually affected in the fact that they are self-conscious, they have a low self-esteem because they're always wondering, what is someone who's looking at my eyes thinking? Why is my eye so red? So even Pinguecula is an intense thing, actually, the eighth reason people fly to me. So you can imagine how much it bothers people. It's just that they haven't told you well enough or you haven't listened well enough. So Pinguecula is where we'd go also. Now, these are day one patients, all of them different ages, sex, from all over the world. And this is the appearance you want. Their eyes need to be absolutely sparkling white, painless, smiling before they fly out. So again, please focus on the slide. I want you to look at or imagine this outcome even before you start your surgery. These are patients, this study in particular that we are sent out for publication, 18 years follow-up. These are, again, doctors, lawyers, but you can see their facial expressions, which to me is my driving factor. All of you know, the way I practice, I have let all my patients go on social media and share what they feel. To me, that is the most highest level of accountability. No other thing can match it. No spot on a scattergram or a graph can show you really how the patient feels. And these are patients, again, high IQ, very demanding, but for them to go on social media and share or take pictures with you is the only testimony of success. So please look at this again. Now, this is how patients document their success nowadays. Again, these are all of my patients. We have permissions from everybody, but you can see how they document their success. You see that man on the right, he's got, before after pictures. This is how they go on social media and write about how they feel. And really, it changes their lives. So pterygium, pinguecula, ocular surface surgery is really important. And it's extremely important that we take it to a cosmetic level because you are changing their lives. So even patients with lateral pterygium, again, I'm first showing you a few things so you can get acclimatized. And actually, I want you to be addicted to how your patients look next day. So you can see a patient with lateral pterygium also, same outcome. Patients with extreme recurrent surgery or pterygiums of many times when they fly in, you still want the same outcome. You do not decrease your guard. You want perfect cosmesis, real excellent vision, no pain, and that's our goal. When I teach premium cataract surgery or premium refractive surgery, the bigger thing that I insist doctors understand is it's not just about the lens. That's the biggest mistake that's going on all over the world when I speak on these topics. Doctors are always asking which lens. I'm doing premium surgery. Well, by putting a special lens in just because it's multifocal or something doesn't make it premium in any level. It's just an ingredient. Actually, for fun, because I'm home, I made a video on social media. I don't know how many of you have seen it, where I explained premium surgery like cooking as a master chef. You don't just focus on one ingredient, you plan the recipe. The recipe starts with ambience, how you approach the patient, the place where you work, how do you treat the patient, how comfortable are they, how confident are they. Then surgery takes off and you land at your outcome. So this is the surgical suite of design, and that's patient comfort is most important to me. In a quick nutshell, I'm sharing with you in one slide the cycle of a patient. Again, this is one particular patient I just picked because of the cycle. You can see me meeting with them before surgery, right there on the sofa in my surgical suite. I meet with them before surgery, sit down, again review with them, having already met them when they fly in. Then you're seeing in surgery, even though I always have people watching or coming in to observe surgeons, industry, you do not want to disturb the patient. You are okay with everybody watching, but you are focused on the patient. The patient and you are one. That's very important. Again, that's what's premium. And the goal that you have here is where you're taking the patient. You can see immediate post-surgery, how patients react with thumbs ups and laughing and coming out laughing. Immediately after surgery, they take a picture or they want to put up a selfie. These are patients of today. You cannot stop that. You cannot avoid that. So might as well enjoy it. It's fun. And they want that to show their families why they flew to this distance. You can see the smiles on their faces. It shows you the gratitude. It makes it more interesting, more gratifying for you to do these surgeries at the cosmesis level. Also, these surgeries come with a very high price price for the doctor, because while these patients are taking pictures with you, going on social media, telling the world how great you are, they're also policing you all the time. You can imagine, I say this every time, even a plastic surgeon has it easy because if he makes a mistake, you just cover it up with clothes. But with the eye, pterygium pinguecula surgery, you make one mistake, you make the patient more red, it's over. They are looking at their eye every second they breathe. They're always going up to the mirror and wondering, what's that red dot? They forget that they're human and that you aim for such an excellence that their eyes are sparkling white. So again, I have not seen this to be much of a problem over the last 2 decades of doing this surgery, that no one really calls and bothers you, but yes, they are very involved. And that's the reason they flew, remember? So they're very involved post-op. They keep looking at their eyes in the mirror. They keep thinking about, how am I doing? And imagine how much you have to be accountable, because they're sharing with their doctors, their families. If it even goes red a little bit, they're calling you. Now, isn't that the same expectation you have in your premium cataract LASIK patients, right? If they don't reach 20/20, they are concerned because they came in with a normal concept and you are taking them to excellence. So this particular patient, Tracy, Minneapolis, she actually, unbeknownst to me and later known to me, started a complete YouTube channel with my journey with her, where she came in for her first eye, then flew back for her second eye, and she would record me even when we met before surgery. So you can imagine the accountability now. You are being recorded before surgery, where she goes, to all my thousands of followers, here I am with Dr. Gulani, and I'm still to go my surgery. I'm very excited. So imagine you have to perform. That's the point I want to drive home today. Patients are expecting. You are accountable. Why not perform anyways? So this is what's happening. If you see down here, another patient of mine records her eye every month and posts on Facebook. So imagine, as I was joking in my recent article I've written, I said, we are being evaluated even while we are sleeping. So as a doctor today, you're being evaluated, you have to perform at that level. So enjoy the ride. Why not do it? Now, here's another fun patient. This patient of mine, I had operated 12 years ago on his left eye for pterygium. His doctor called me and said, hey, doc, you had a recurrence. Now, it was very hurting to me. I have had one recurrence in over 600 cases for this paper we've submitted, over 18 years for this particular technique. And I was like, wow, okay, I need to see it stat. Patient walks in, and I remember my patients. So I'm like, what happened? And he's like, I have a recurrence, doc. Your surgery went bad. And I told him, that's not the eye I operated. I operated on your left eye. That's the eye we did not operate. And we had a nice laugh, and I took him for surgery and corrected him right here. So it's very important. What I'm sharing with you right now is the mindset of the patient and the doctor. You have to be a team as you're working. Only then can you take it to a level, again, analogy of your premium cataract surgery or premium laser vision surgery. Patients are expecting beyond 20/20. Anything less than that is a side effect. Anything bad or side effects of visual distortion is a complication. Similarly here. All of you are excellent surgeons, especially I know you all are doing a lot of pterygium surgeries, but each patient, if you can take to a point where you bring them to the mirror next day, that's my desire for all of you. So I'll stop for a second now, take you to a video. I have many, many videos. Again, I'll cover everything as much as I can. Right now, I'll take you straight to one video, look at it, and then we'll go through some more slides. Can you see the video now? Can everybody see the video? Can you hear it?
Yeah, we can hear the video, audio.
Yes, can you see it though?
Pterygium is an intriguing pathology that can present itself in various tissue distributions.
See the video, Dr. Gulani?
You can.
Yeah, we are able to see the multi slides.
You cannot see the video?
No, we are not able to see the video, but we were able to hear the audio of the video.
Oh, that's odd. Because you are sharing screen here.
Probably it's not playing in the main screen of your laptop.
It is playing on the main screen.
Okay.
It is.
So is it the screen still shared?
It is. Let me do one more thing. Hold on.
Yeah.
Vascular
Now?
pattern.
Can you see it now?
No, doctor, not it.
Wow. Okay, hold on, because the screen is shared. It's saying stop sharing.
Yeah.
Videos are very important. I have to show you.
Yeah.
Now?
No, you'll have to start sharing your screen now.
Yeah, I have. I'm on share. Hold on one sec. Let me do this now. Now, can you see?
Yeah, now we can.
Lovely. All right, so I'll just take it back a little bit quick. Here we go. Ready? Can you hear and see?
Yes, we are able to see that.
Lovely. Perfect.
Pterygium is an intriguing pathology that can present itself in various tissue distributions and vascular patterns. Using the three-step technique, the pterygium can be removed following the iceberg concept with mitomycin C application and glued amniotic grafts. With this iceberg concept, we're ensuring long-term success, starting day one. In this case of pterygium, I first start with a fixation stitch, followed by delineating the entire pterygium with intralesional anesthesia. Trace the entire pterygium down to its roots, anatomically delineating, literally cutting down its tentacles as it gives way, and the entire lesion is seen as here. Peel off the corneal portion from posterior anterior movement.
Everybody okay?
Use a 64 blade to clear the cornea, limbus, and episclera, literally like an eraser in fast, smooth movements. Receive the amniotic graft. Place it onto the scleral area. Sweep it into place under the conjunctiva. First component of the tissile glue, delivered subamniotically in a controlled fashion. Sweep it into position, so you're also squeezing out excessive glue. Second component of the tissile glue, again subamniotic. Once again, sweep the amniotic graft and squeegee at the same time for good adherence. You can also place glue between the conjunctiva and the tenons, flattening this area as well as giving an excellent aesthetic appearance that will stay next day.
Delineating the anatomy is very important. Clearing the medial rectus, very important.
Using a blade, I now, using a single sweep movement, cut down the excessive amniotic graft along the limbus in a controlled fashion, deep enough to cut the amniotic graft, but not the cornea.
No cutting
As
the
you can see
cornea.
here.
You don't want to induce any astigmatism. Never cutting on the cornea.
And peel away this excessive amniotic tissue to an elegant outcome so these patients can literally wear their contact lenses next day or get ready for refractive surgery soon. Excess glue is removed using Weck-Cells. An immediate post-op appearance. This is her left eye, we did, Kaggle. And right eye, 1 day post-op.
Please notice the comfort.
Dios mío. No lo puedo creer, no está. Es un milagro. Es un milagro grande.
Oh, unbelievable. That looks great.
Every patient is made to do the mirror text next day.
Wonderful. Nice and clear.
That's Sherry, day 1.
Holy cow, now the see.
So this is a very important thing. Every patient has a mirror text.
Amazing.
Yeah.
Completely different. Wow, they're on.
I wasn't expecting it to be that clear.
I know.
Wow.
And this is the morning after.
That's day 1 post-op left eye.
Yes, you're welcome.
In cases of recurrent pterygium, the same principles apply.
Intralesional
Intralesional anesthesia to also delineate the entire lesion. Cut down the scarred conjunctiva. Find the vasclera that the previous surgeon must have prepared.
It's
And
always
trace
there.
the entire pterygium from posterior anterior approach once again, finding its tentacles and cutting carefully but diligently till the entire lesion is removed in toto.
Literally, it comes into your hand as you cut the tentacles. You don't
This is
have
the
to
entire
chop.
lesion. At this point, also trace any evidence of previous leftover pterygium that can be removed. Peel off the corneal scar.
No cutting, peel off, please.
Using a blade, smoothen the cornea, the limbus,
64
and the
blade
episcleral area.
used
Once
as
again,
an
fast,
eraser.
smooth movements of the blade to smoothen the entire junction.
Literally none to
preparation
very
for amniotic
minimal
graft.
cautery. None to very minimal cautery. Very important.
Clean
Use
the
the
area
blade.
for any excessive tissue.
Ready for receiving here.
High mag picture. Accept the amniotic graft. Place it onto the
You
area.
can use different ones.
Glued into position, once again using the 2 Wexel technique to squeegee the graft. Now using a blade to trim the excessive amniotic graft at the limbus.
Very
In a
minimal glue
simple,
needed.
smooth movement, peel off this excessive amniotic tissue. Sweep the fornices for any excessive glue that may prevent keratitis next day. Antibiotic drops. Immediate post-op appearance of a recurrent pterygium. 1 day post-op, following recurrent pterygium in her left eye.
Again,
Lift
please
your
notice comfort, extraocular movement.
Wow. Beautiful.
Very clear.
Yes. All gone.
In case of Pinguecula, intralesional anesthesia, once again trace the Pinguecula down to its roots. Blade to smoothen the limbus and episclera. Clean this area, prepare it for the amniotic graft that is received here. Placed into position. First component of the tissue glue
Again,
delivers
very
subamniotically.
controlled, very
Sweep it
minimal
into
glue.
position with squeezing the amniotic graft simultaneously. Second component of the tissue glue, again subamniotic delivery. Once again, sweep into place, squeegee at the same time so we have great adherence and placement. And excessive glue removal. Sweep the fornices. Using the blade, once again, trim the amniotic graft right at the limbus for a very elegant appearance and functional outcome.
And vision is
Peel off
always in
this
your mind,
excessive
right?
amniotic tissue. Do Wexel technique, squeezing the graft into position, removing excessive glue at the same time, testing that the graft is completely adhered. So we've had no graft slippage in our series of cases. Immediate post-op appearance.
Wow. I never thought it would be possible. Oh my God.
It's beautiful.
I love it. Wow. I'm going to be staring at it for hours now. Oh my
amazing.
God. It's amazing. It's amazing. The next day. I don't want to cry.
No.
It looks so good. Oh my God. Thank you. Thank you so much.
Whether it's a Pinguecula, early pterygium, or aggressive, recurrent pterygiums, a consistent next day outcome has been achieved with long-term follow-up. Patients of all ages, race and sex have experienced these consistent outcomes of here today, gone tomorrow.
Right, so we get back to our slides.
Thank
Okay, can everybody see again?
Yes, we are back onto the slides.
Okay. So from that video, I would like to stop for a minute. What did anybody in the audience, any questions? The reason I want you to see these videos is, one, like I said, our mindset has to change. We want cosmetic looks. Second, when they're smiling and laughing like this, understand, for example, the last girl that you saw in the mirror came all the way from Vancouver, she's a model. You can imagine the smile, it's also telling you how much they were hurting. So get addicted to this feeling. When I'm operating, I really am in a different zone. I'm actually seeing them see themselves in the mirror next day. That's how I operate on all my cases, whether it's a very complex LASIK, very difficult cataract. To me, in fact, the article I've just written, I call it Show Me the Patients. My point is, I don't want to see anyone's surgical acrobatics doing things in the eye, crazy stitches and vitreous. Show me the patient is smiling, comfortable, wants to hug you, wants a picture with you, and is blown away with their vision. If they cannot show me that, I don't want to see their surgery. So that's the level I want all of us to be at, that I don't want anybody to show surgical acrobatics if the patient cannot be shown, because it's very easy for a doctor to say, I'm doing great or my patient's doing well. But a fully paid patient on camera wanting to say that they are doing great is the only indicator of success. So are you with me till now? Now we'll go into the concepts. I call this SPARKLE concept acronym: sutureless pterygium, amniotic reconstruction, laminar keratectomy, excision. Never use burrs, never use blades on the cornea. Respect the cornea because that's vision. We cannot let vision go down. Three-step technique. First, you saw me in every case with a pinguecula or pterygium, I was dissecting right up to the roots. That is vital. I believe that is the most important part of not having recurrences and the patient's doing so well. And of course, mitomycin C application in 100% of cases for 20 seconds. Glued, meaning sutureless, and the glue I use is Tissile glue, no financial interest. I just want elegance. I hate stitches. I want the eye to look great, to move perfect, no pain, and the patient vision is also restored to some extent. So this is how patients next day look. If you can notice the lid area, it also has makeup. So patients go that far, even though you're constantly telling them to be careful. Next day, post-op of a pterygium and a pinguecula. This is the iceberg concept. See the amount of lesion I remove compared to what most doctors remove. The small part actually is pretty big. It's the whole pterygium that was visible. But the entire large part is what was existent right up till the medial canthus. Then tissue grading. So I don't like to grade things as making it more difficult for me. I constantly teach these things because I do a lot of complex corrections. Don't call things difficult and complex. Grade it in your mind. In my experience, even a small pterygium, and I'm sure you've done many, you will notice this too, sometimes the small ones are much more gritty, like a raw pear, more difficult to remove than a large atrophic pterygium in an elderly population which peels off. So over experience, you learn to see that and you visualize in your mind how the surgery will go. Vascularity, very important. The more tortuous the vessels, the more active the lesion. Again, next day post-op is what I'm showing you. You can see the BCL in this patient because they were flying. I just want to make sure they're fine before they go back to their doctors. No matter how aggressive the pterygium is, constantly, like I said, in my mind, it's how are they going to look at themselves in the mirror. Again, you see here lateral pterygium, no difference. Again, different kinds of pterygium, peripheral pterygium, pterygium that are atrophic, that are along the limbus. It doesn't matter to you. Don't go into the esoteric definitions of what's grade 1, 2, 3. Look at it, decide you want cosmesis, you want the same extent of surgery. Lateral pterygium, you can see again day 1, and you can see the extraocular movement and everything reactive to that point. Very aggressive recurrent pterygiums that are sent to me. Again, I do not look at it. I don't call it recurrent or complex. My whole thing is, I'm already visualizing the patient with a sparkling white eye next day and in the mirror. That's it. Again, aggressive pterygiums, recurrence that are sent over, you want it the same way. Or again, squamous cell carcinoma in lieu with the surgeon who does also therapies for them using chemotherapies. But the surgery, when I do, I still want cosmesis. A few things that I've seen as side effects in some cases. This was a bubble wrap sign I had seen over 15 years ago, self-resoluting, scleral melt, very minimal. Patient was elderly and artificial tears, and they were back. Patient has subamniotic bleed because they flew to New York after surgery, self-resolving. And the beauty is the amniotic membrane, as you can see, is containing the hemorrhage. It's a rectangle. And the Tissile glue, guess what, is preventing the bleeding. So you're fine with it. Again, same concept here. This is how patients look in the mirror. Please get addicted to this look. It tells you how much they were hurting. And many of us, when we are not aware of these levels that we can take our patients to, are telling them that they're just being vain and it's no big deal. When the pterygium will affect your vision or affect your lifestyle, come back to us. No, it's hurting them. When you first look at anybody, you look at their eyes, and that's why you decide their personalities. And these patients are impacted, like I've described before. Low self-esteem, constantly self-conscious, even to the point of depression. That's why they're flying. Again, you can see here, patients with multiple previous surgeries. This patient was from Oklahoma. You can see the unoperated eye, the extensive recurrent case, but still the same outcome. Very high recurrence, very high tortuosity, same thing. Patient, this was the other eye, the bitemporal pterygium in this case. Her vision was also 2200 because you can see it's nearly blocked and high astigmatism. You don't care. You want the same outcome. That's how she looks now, and very excited And this is the picture she took and she sent me when came back to her Oklahoma surgeon a few months ago. Another patient, extremely aggressive, bitemporal, highly recurrent pterygium by the time she was sent to me, vision very poor. You see what we did here. Again, my plan is I want the cornea to be crystal clear, no cutting, please, no blades. You want to clear the entire fornix, restore the extraocular movements, increase the fornix sizing from the shortening, from the scarring. And in this case, I also fooled her conjunctiva by moving the upper lateral down and the lower portion out. So if you can see on the last section of the slide, and you basically give that tongue of vascularity for that extensive growth and yet confuse the conjunctiva in a seamed way, so there is no chance of recurrence. And here you can see this patient today. She actually runs one of the most amazing Thai restaurants, and that's her cornea, perfect vision, back to her profession. This patient I'm observing was sent to me after multiple surgeries. He had a scleral melt, a severe calcific area with repeated lashes and things getting stuck. In fact, I just did his surgery last month. He's doing very well. Again, I observed him for some time just to see if this was going to hold itself, and it gets worse over time. So this particular doctor, I think they kept the mitomycin for too long and caused a severe scleral melt and then just left it. Now, how do we correct scleral melt if it happens? Again, don't panic. The bigger thing, may I please request you again, is think about this patient in the mirror. It doesn't matter how complex they are. Think about them in the mirror. So this is the case which I used a lamellar cornea to fix this patient. She's a model, and I placed it over there. I took some tag sutures, 2 sutures up in the fornix, but otherwise glued it down to give it a firm strength to the cornea and cosmesis. And here she is. 6 years post-op, now she's 8 years post-op. Again, cosmetically perfect and very happy. Here's a patient with scleral melt where I use a Pterygium. You can use whatever patch systems you want. I don't dwell too much on that. I want results. I want the same look in these patients. I want the same appearance, restoration of anatomy, clarity of cornea, and beauty of the eye. You can see this over here now. And there's another procedure where I've seen a lot of patients flying to us with complications being used, eye bright. These patients also come to us, some of them with scleral melts because of the medications that I use with it, some of them with severe complications of scarring. Patients, this particular patient I'm showing you to show you that actually they didn't have that much of a problem, but still the wrinkled look of his eye was something he couldn't tolerate. So we took that and we operated on this eye, and you can see the smooth look now with the sutureless amniotic surgery, and the patient is thrilled and flew back home after correcting his eye bright complication. So these are those cases. Now you come to ProCara. It's a technology which I've used in extensive cases, more to recreate the fornix area while my cornea is healing in these extensive cases. Patients recurrent pterygium corrections. Again, these patients just adore you. They drive or fly back to you for years. They don't want to go anywhere else for their post-op, and it's fun. I mean, you just see them for a minute, there's nothing to see, but then I sit down and have lunch with them, and it's very, very rewarding. So that's what I constantly say to people, to eye surgeons: get addicted to your patient's love and appreciation, because that's what drives you in surgery. Now, why are all these things important? Not only cosmesis. When you do pterygium at a level that you're excellent and consistently excellent, you can now attack pinguecula, because pinguecula is a smaller lesion. You can't afford to make a mistake, right? When you're doing surgery, today I do on patients who are 20/20, because the SWAT teams and Navy SEALs who have flown to me, I want 20/10 vision. But to reach 20/20 consistently first is the step you must be confident about. So the importance of doing these surgeries cosmetically well is you are now able to do refractive surgery. You're now able to make them premium cataract surgery patients, candidates. So many patients of yours who deserved premium cataract surgery, laser vision surgery, whatever, keratoconus intact surgery, now are candidates because you haven't cut the cornea, you have restored the tissues, the eye is back to normal and precise for your accuracy. So here's a patient, we have to maintain their pseudophakic vision to 20/20. So you cannot harm it while you're removing the pterygium, very important. Here's a patient, we remove the pterygium, we put in a toric lens, bring them to 20/20. Here's a patient, you can put in a multifocal lens after pterygium, because after you've done it the way I want you to, the patient is a normal patient, expecting great vision at all distances. Here's another patient, I want to show you the stages. Not only was there a pterygium, that was all the way to the center. You did a lamella fill with the amniotic, healed the eye, multifocal lens, and laser to 2020. Here's a patient which is, though it's a granuloma lesion, not so much a pterygium, the concept applies. You want perfection in the anatomy, then you are so accurate, you go and do an ICL surgery in this young man and bring him to 2020. Here's another patient, a couple did pterygium on them years ago. Later, they came back and did multifocal lens for them. Now, at this point, they're about 12 years post-op, enjoying their life at the age of 70, going skydiving. So you can change people's lives. It is important. That's the payback. Again, you see here, day one, outcomes of all these patients, just prototypes of patients from all over the world, different cultures, and how they are and what they see. Our study, a quick brief overview of the study. Basically, I have seen midterm issues, and one patient distorted pupil, one patient discolored sclera, mild ptosis in one, self-resolved scleral thinning, amniotic, and one recurrence in our case series in this study. These are patients 18 years post-op. Again, you can see them, different kinds of people from all over, different professionals, but the happiness and the consistency, that is very, very important to me. For those of you, we are building now a lot of my videos and surgeries on our Instagram and Facebook and YouTube. You're welcome to go there or contact me or follow, and I can speak to you, and whatever questions you have, you can take that. So with that, I finished the slide parts, and I want to give you time for discussion. I have tons of videos more, but let's take it to discussion so you can Q&A me. I call it grill me. Are we ready?
Yes, we'll go first with the chat questions, Dr. Gulani. And before that, I would really like to thank you for this wonderful presentation. I think it was a great eye-opener for all of us to think of a happy patient post-operatively as if they are seeing at the mirror. And that is a real lesson to learn from you. And so going on with the chat questions first. So first question was whether you use mitomycin for all patients.
Yes, I do, for all of them, 100% of them.
And the dosing is like 0.04% for 20 seconds, followed by a thorough wash. Okay. Yeah. And there's one other question. How do you tackle the overlying conjunctiva? Should we cut or should it remain there?
Yes, absolutely. You're cutting it, but not, basically you're cutting very minimal. So think about it when you saw the surgery, is I cut it in a C pattern, right? I look at the lesion. And again, I'm not looking at conjunctiva now. My entire focus is I'm imagining the lesion like a complete iceberg going right up to the medial canthus. So I cut the conjunctiva maybe about 4 millimeters out from the limbus, and that portion I will throw away. The remaining you want nicely to drape over the amniotic tissue. You remove your pterygium from underneath all the way to its tentacles from the medial canthus. Bring it all out. It's over. No need for cautery. There's no need for chopping. You're just cutting the tentacles gently, and the pterygium comes in your hand because the tentacles are getting cut. So you remove the entire lesion, the whole mass. No cutting on the cornea, no burrs on the cornea. Peel off the cornea. So you're maintaining vision, not inducing refractive errors. Then when you put the amniotic graft, you saw me in this C pattern, I let the remaining conjunctiva drape over it.
Yeah, and how do you avoid cutting the medial rectus?
Oh, great question. So first of all, here's the first important thing I'll say on that note, medial rectus, is the fact that you must see the medial rectus. Only then will I know that you have dissected all the way where I want you to. So you must see the medial rectus. Now, in recurrent cases, you know the importance of that. You must see it isolated with a muscle hook to make sure anatomy is perfect. 100% of cases of recurrence, you will find the original pterygium there. That's the reason for it. So that's the one thing. Second, so identify it. Two, when you lift the pterygium off, cut vertically down, you'll never hit the medial rectus. If you cut this way, you'll get confused. So if you pull the pterygium in your hand, and even though you feel like, my gosh, I'm very close to the medial rectus, cut vertically down, and you'll never hit the medial rectus. Minute you cut the pterygium, you'll see a buttonholing happening. Medial rectus is a beautiful light brown look of the muscle glistening underneath. That's what you're looking at. So you will avoid it if you cut from up down.
Okay, so that's great. So because you use mitomycin C in each of your case, how frequent do you see scleral melts as a complication?
So in our series, like I said, I have not. I use it for 20 seconds, and then I use a BSS, flush the entire area with BSS. I have seen some self-resolving scleral metal like I showed you there. And it has not been a problem in our study. Also, maybe because I don't use too much cautery. Very rarely will I use cautery if I do want some area like in recurrence and stuff, and I'm seeing a large blood vessel going around somewhere. But I believe, having seen patients that come to us, extensive cautery, a lot of mitomycin spread everywhere. I mean, mitomycin, when you're using, use with a vexel, like 5 pieces, between the conj and tenons. I don't let it hit the sclera, if you saw in the video. And I keep a dry vexel in my hand. I just keep on drying the scleral area. I don't want it to go on the sclera. So that's first thing, making sure it's between the conj and the tenons. That's why anatomical delineation very important. 2, 20 seconds. 3, avoid excessive cautery. I use the 64 blade if you saw in a very fast movement. When you use a blade fast, that's also my corneoplastic principle to remove scars from cornea. A fast blade acts like an eraser. It doesn't cut or chaff. So that's how you prevent a scleral mount.
Okay. So one point to note is like avoid excessive cautery because we tend to see a lot of bleeding during our pterygium surgeries. So do you follow any specific medications, topical medications pre-operatively?
Yes, please. Yes, I should have mentioned that in the surgery. I do use a Vexel. You know, when I removed the pterygium, you saw me take a Vexel, which is dipped in epinephrine, and I put it straight into the medial angle. The reason for that is twofold. One, it has epi in it, so it may take care of the bleeding if there is bleeding. 2, it's creating my space for the amniotic graft to go over the medial rectus. Now, when you see bleeding, here's what I teach doctors all the time. I say, don't look at it. Doctors get so concerned, and please take this the right way, about the bleeding. They're just going on and on cauterizing. If you've seen the blood in pterygium, of course, you shouldn't have more. How do I know you have no bleeding? It means your anatomy and the dissection was perfect, especially in recurrent cases. So this may sound controversial to you. In a recurrent case, actually, I want no bleeding because if you have bleeding, it means you chopped and cut and kept cursing the previous surgeon. In fact, the first thing I do in a recurrent case is find my scleral plane. So I hold the recurrence, I get down. The minute I see my sclera, home game. Because now what I'm going to do is I'm going to lift that entire plate of armor up, no bleeding. So if you see bleeding, number one, there's something wrong in the anatomy and dissection, the way it's being done. 2, don't bother too much. It will self-resolve itself. Keep working in your surgical area. Just dry it off. Use minimal cautery. Very important, please.
That was really a good point to note. So when we are in the right plane, we see very little bleeding.
Absolutely. I mean, that is, if I would say 100%, barring exceptions, if I see bleeding, my point is, doctor, you're on the wrong plane and you're chopping things. Do not cut. Just cut the tentacle, snip the tentacle. You saw me do that. The whole pterygium's coming off in your hand. That's very important.
Okay. So the next question was, because the post-operative first day pictures were like patients were absolutely without any lid edema or congestion or no signs of inflammation. So what do you give post-operatively, the topical medications?
Medication, sure. So steroid, antibiotic, and NSAIDs. Steroids for about 4 weeks, 4, 3, 2, 1. And NSAIDs for about 2 weeks. Anything you use. I use Prolenza, Elevro once a day. Antibiotic, I use Besivans, anything you can. Steroid, I use the Durazole, but again, any steroid you want. So steroids for a month, NSAIDs and antibiotics for 2 weeks. That's it, pretty much.
Okay, so thank you so much. And about the amniotic membrane, so all of your cases had amniotic membranes. So you don't have the habit of using conjunctival autograft. If so, why?
Right. So again, very important to me. I'm a stickler. I like beauty. I want absolute perfection in the eye. So the tissue that comes to me, in my mind, is I want something transparent, that's glistening, that has ability to heal, whatever ability it has to heal, and can stick down with my glue. And I'm not damaging the remaining conjunctiva by removing it. Now, there's another practical point in some places. It's difficult, it's expensive to get the amniotic tissue. I understand that. So if someone's using conjunctiva, if you see, I don't get into these discussions about conjunctiva or what kind of amniotic tissue, having used all of them. Because to me, 90+% of the success is still the surgery. Same things like I repeat, whether I'm teaching advanced LASIK or cataract techniques, 90+% is surgery and the expectation that the doctor has to drive for. So even if someone's using conj graft, I have no problems. Make sure it looks beautiful, make sure it's staying in place and you haven't damaged too much of the donating eye. That's my point.
Okay, so that's perfect. So one more question is from Sonali Prasad. Sir, once I had nodular episcleritis below the pterygium. It got visualized only after removal of pterygium. I used a cautery to take care of the bleeding and scraped it off a little. What other technique could have been used?
So what's the doctor's name?
Sonali Prasad.
Sonali. Again, remember what I said and spoke in this full hour now. I don't care what you come across. I'll let that statement resonate with y'all. I don't care what I come across, how difficult the situation is, what I find under the rock. I don't care. I want the outcome in the mirror. I want the patient to look amazing, feel amazing, be blown away and flying off next day. So let's say you found nodular episcleritis. Now let's think for a minute. It has nothing to do with your surgery. It's a problem. It's a problem which is a disease in the eye which needs treatment, most likely steroids or whatever. So what you did at that point, I'm okay with it, but it's two separate issues. Your pterygium surgery doesn't impact it. So you'll stay away from the scleral area there. You know you have to come back and do steroids or something for this patient. I'm all right if you cauterize it, but it's an unrelated discussion to the surgery. I still want the surgery to look like nothing happened.
Okay, so that's right. One other question was, do you use BCL for all patients, bandage contact lens, and when do you remove it?
No, I don't. I only use it when the pterygium was so far on the cornea that when I peel it off, you're obviously causing an epithelial defect. And that's when I would use the BCL for them to fly off to their doctors wherever they go. Majority of the patients, I also patch these cases after surgery in case they are extensive by temporal, recurrent, and the patch already heals the epithelium by next day, as you know. So BCL is very rarely to be used now. Remember this other important point. We talked forward, let's talk backwards for a minute. We want to do these surgeries not only for the patient to be cosmetically amazing, but to also turn them into candidates for your premium cataract, refractive surgery. Look good, see good, right? 20/20 plus vision. Look, think backwards now. Millions of people have had LASIK surgery or premium cataract surgery. We also have a responsibility to maintain that vision while we are doing our pterygium surgery. You cannot do pterygium surgery, cause distortion on the cornea, and now their vision is impacted poorly. So very important. So in cases where I find a LASIK flap or a SMILE flap, I will put in a BCL for a day or two. That's the way I do it. So BCL is not needed unless there's an epithelial defect, and then I would do it if I need to take extra care of someone's LASIK or SMILE flap or RK case, if you may, then I would for a day.
Okay, thank you. So the next question was, when do you plan the cataract surgery after the pterygium excision is done? How long do you wait for the refraction to stabilize?
Same answer again, as long as it may take. So I'm very patient. I refract the patients myself. I first refract them at 4 weeks, then I go to 8 weeks. By then they are pretty much stable, but I would wait about 3 months in most of these cases and do the surgery.
Okay, so there's one other question from Dr. Murtuza. How much does this surgery cost for the patient? Does insurance cover it in US?
So some of the cases are covered by insurance, but they have a very strict protocol. It has to be pterygium, it's on the cornea, impacting vision, all those things have to be proven. Otherwise, the cost can range anywhere from $2,000 to $5,000 because of all the materials used with the surgery. Now, amniotic tissue also, whether it's covered by insurance or no. So that's a different discussion of cost factor, insurance, non-insurance related. To me, the other important thing here is when a patient is discussing this with you is I like to talk about this as I spoke about this when I was there at Arvind 3 years ago, is the business aspect of these surgeries. Always, always believe that the patient wants the best and you want to give the best. I feel it's a misnomer that many doctors have that we must decrease our choices for the patients based on the cost. I have never found that to be true. You let the patient know exactly what you need for their surgery, they will plan it and they will afford it because it's important. Similar aspect of mindset for your refractive surgeries, anything you do in your practice. I have always found that to be true. And I repeat, the outcome further confirms that choice for that patient. Meaning, if you go to Tiffany, you're not looking for a coupon for the diamond. You're looking for the cut, carrot, and clarity. Give them the cut, carrot, clarity. Everything else is secondary.
Okay. So there was a question from Dr. Damayanti. What is the rate of recurrence in your pterygium surgeries?
Well, we've had one recurrence in 600 cases for the paper that we've submitted right now. And I again believe, even though I use amniotic in 100% of cases, I believe the biggest point is the surgical dissection. Very important, very important. You know, I joke about this all the time when doctors are visiting. I say pterygium is something we allow our first year residents to do, right? In med school and in medicine and in residency. In fact, it's the most difficult surgery I want it to become. Think about it. I said this at the start for people just joining in. I see a lot of people now further joining in. Think about this. Even a plastic surgeon hasn't this level of accountability as an eye surgeon does. Think for a minute. You do any cosmetic surgery, you make one mistake, you cover it up with clothes. It's over. Nobody knows. You make one mistake with pterygium surgery, all your life, that patient and you are haunted. So as I said at the start of my lecture, number one, do provide these outcomes. It's what patients deserve. We have to perform. Two, it's tremendously gratifying. It comes with a little price that you're held to a higher accountability. But has that stopped you from performing advanced LASIK, advanced premium cataract surgery? All the surgeons here, I'm sure will say yes if I ask them, are you gratified that you do those surgeries? So yes, when you see your patients at 20/10 vision, consistent, it should be addicting. That's the word I use, addicting. So when I'm operating, I don't even think about my surgery. I'm in a zone where I'm thinking, how will this patient look tomorrow and 18, 20 years from now? So I completely disregard my driving. I'm so focused on my destination and that my passenger should go at such a nice, comfortable way, listening to amazing music in the ambience of a phenomenal car. Last thing on my mind is surgery. Therefore, you see me in all my courses when I teach. The one thing I don't like is every surgeon teaches cooking, surgery. Nobody talks about outcome, patient experience, and consistency. That's where you have to be a master chef. Just not burning food is not being a good cook. Gourmet meal all the time that blows people away. So if we focus on pterygium surgery with that mindset, never look at the complexity or how large the pterygium is. Your mindset is, I want perfection in the mirror, painless appearance, long-term. And if needed, refractive surgery. So this is the goals of today's talk and how we should get there. So any other questions?
Yeah, so there's a question from Dr. Manish Agarwal. What do you use for scraping the cornea?
Scrape. I don't scrape the cornea. I scrape the limbal area with the 64 blade as you saw me do it. Again, I have tons of videos for you. I'll put it on for you wherever you want. It's already on our website, but I'll put it somewhere for you. I'll talk to you all later. But 64 blade, I use it at a very high speed, extremely high speed. High speed because speed decreases the cutting aspect. It makes it more like an eraser. So if I see blood vessels on the sclera, you'll see me doing that over the bleeding and the blood vessels. And it's amazing, your sclera just clears off. And by not going slow, you're not cutting or chaffing. And similarly on the cornea, you don't want to scrape the cornea besides doing that. Now, any lesion on the cornea, I call it removal in a centripetal manner, meaning you lift off the pterygium, peel off the cornea. Use the cornea as a resistance guided platform. That's the concept here. So please avoid cutting. Never use burrs and stuff on the cornea. That's an insult to the cornea. Remember, again, while I'm doing my surgery for pterygium, my mind is completely also focused on vision. Neither can I take away the vision that their refractive surgeon somewhere else must have corrected. Neither can I take them from the candidacy away of becoming a refractive or premium cataract surgeon.
Okay, so the next question is from Dr. Aditi. Sir, in extensive limbal involvement in pterygium cases with minimal healthy limbus pre-op, have you experienced limbal stem cell deficiency? If yes, how are you planning pre-operatively?
Great. So again, different disease concept, but my desire doesn't change. If it's limbal stem cell deficiency, you can do the SLED technique. That is very easy to do. Again, you use the amniotic for it anyways. Do it combined with your pterygium, right? Cover the cornea with your amniotic, put some of the stem cells there, and go home with a BCL, of course. So my point again, please, that's an excellent question, but I want to come back to my mindset. That's what I'm trying to arm wrestle with you. I do not want you to get scared of what you see. I want you to be non-changing in your desire. So I don't care. You call it slit. Let's call it a tumor. Let's make it absolutely horrible. I don't care. I'm still visualizing that patient looking beautiful, sparkling eyes, and in the mirror. So if you found something like that, I would address it along with the pterygium. And again, what would you do? You would do a slit for that and help that patient out, put in a BCL, monitor the cornea, but that's nothing changes. The medication doesn't change, your desire doesn't change.
Okay. So you'll be doing a combined procedure.
Absolutely.
Yeah.
Now,
So
one thing, sorry, let me interrupt. When you say combine, I get this question a lot too. Would you do that with cataract surgery? Would you do pterygium? The answer is never. Again, accuracy is your goal. When you're doing cataract and LASIK or whatever, among 28 different refractive surgeries, you want perfection. You cannot have perfection if you're doing two variable surgeries. So wait, perform. Unless the pterygium or pinguecula is refractively neutral away from the cornea, there is no need to combine the surgery.
okay. So even if the cataract is very mature, you don't combine the surgeries?
Absolutely. Again, if you see, I'm repeating myself. Very important to me. I don't even call a cataract mature or white or whatever. I do some of the most complex cataracts that are sent to me. I want 20/20. I don't care what it looks like. So pardon me for using that language so strongly. I walk into the OR having researched about the patient, having met with them, having personally planned the night before, no rushing through. Surgery still takes 4.5 minutes. Point is, I want 20/20 or better. I don't want anything less because that means I let her down. So even if it's a mature cataract, remember, we want accuracy. The first problem we have with mature cataract is maybe the IOL master A scans are off anyways. Now, if it's that bad, why add another problem of unreliable corneal astigmatism? So I would do the pterygium, monitor my cornea topographically normal, shape-wise constant. Now use all our energies and whatever 30 years experience to come up with the lens power. But to go in without that planning is disservice to the patient. Hence, I don't like words like complex because that decreases our desire to perform.
Okay. So what's your take on using blood as a glue?
So I've done that in some cases when we go and do outreach somewhere. I have no problem with that. Very, very, very innovative. Use blood, I'm fine with it. Again, my point, aim for the cosmesis end. And that question has a dual answer. One, you're using blood, I'm assuming for economic reasons, because the glue does work better in my experience. But using it, I'm not against it because I have seen blood holding it and adhering. So I'm absolutely okay with it, as long as it does it and holds it consistently.
Okay. I guess we're done with the questions.
You're done with questions and now it's morning, I'm awake.
Yeah, you have spread so much positivity and perfection into our minds. I hope that the lockdown is getting over soon and we're all getting a hands-on to a pterygium surgery as quick as possible.
You know, you don't even need surgery. Just sit in front of the mirror and tell yourself that's what you want. Like I say all the time, this is very important, please. It's not the patient who knows what they want. It's you. Perform at a level even before you start your surgery. That's why I showed you the surgical ambiance, the way you sit down with the patient, the way you monitor and plan. It's not just showing up. Like I've said before, and these are numbers I actually give out. If cataract surgery takes more than 4.5 minutes, you're doing something wrong, no matter how complex the case is. If refractive surgery takes more than 3.5 minutes, there's someone doing something wrong. If there's bleeding in pterygium, there's someone doing something wrong. So if you monitor yourself with these principles, now, let me qualify this. I give 40 minutes per patient because of the way I want to treat them before, after, have fun with them, whatever. But surgery should be specific, not delayed. And no going into the eye and fooling around with things and stitching and vitreous, no way. Think of that patient as our family. They trust you, the eye is open, and you want perfection. Now, if we train our mind that way, that's the only secret I can give to anybody who asks me. I don't even think about the surgery. It's the outcome I'm completely focused on and the patient smiling and jumping off the table. So in fact, my article coming out in Ophthalmology Times next month, I've called it, Show Me the Patients. If you remember the Jerry Maguire movie, Show Me the Money. My point is, anybody showing you these difficult surgeries and complex maneuvers, stop right there and say, hey, first show me that patient. Is that patient in pain while you did it? Did that patient get off the table and hug you? And 3, is the patient 20/20? If not, can you please shut the video? I want us to be that demanding of anybody who teaches surgery. Hence, I have done perhaps I think the most dangerous thing. All my patients are online, and the qualifying factor is they've all paid for their surgery. They are the most, if not the most demanding patients in the world's most litigious country. The point I'm trying to share is it's a pleasure to share with you that your patients are your tornadoes going out in the community. Why don't we perform at a level that blows them away? So even if we are in lockdown, there is no need to say, I've lost my surgical skills. No, just sit in front of the mirror, look at yourself and go, I'm going to deliver to each patient. Every patient will be perfect. There is no such thing as complex. There's no such thing as not a candidate. Everybody deserves our full attention, and you are master surgeons. Take your mastery to the next level performance. So today's case study of the lecture was mostly Pterygium, everybody does so well. Cosmetic level, visual level, look good, see good, performing at that level consistently, not getting afraid, scared, intimidated by looking at difficult scenarios. Care a damn for it, just perform.
Thank you so much, Dr. Gulani. I guess the questions are over. I hope there are no audio questions. So if that's so,
I see some chats coming in, but why don't you ask the audience what is their take and what has been their success in this surgery? Because I'm sure someone else has another great idea. Hello? I can't hear.
So we're not able to hear you, Dr. Anita.
I'm looking at the chat while I'm waiting. I think I've answered all of these questions. Minimal redness and good vision for me, sir. This is Sonali, okay? Yes, not minimal, no redness.
Audience, any other questions do you have? You can come on online in the Zoom audio.
I can't hear.
Dr. Anita John, we're not able to hear your audio well. Can you increase the volume?
I can't hear.
Dr. Anita, if you're not audible in the Zoom audio, you can chat with us for your question.
Okay, there's someone asking in the meanwhile, what's your take on cataract surgery outcomes? Do you still perform monovision? So
Yes.
what's the answer to that? Can you hear me?
Yes, we are able to hear you. I think that was a question by Dr. Murtuza for you. Do you still perform monovision?
Okay, great. So again, this is a whole different discussion, whole different lecture. Monovision, yes, but my point is that's not a question. I want the best vision for that patient at all distances and see what they are comfortable with based on my testing for them, including understanding their fusion capacity, the needs for night vision, and 3D. So to me, again, I don't talk about things like monovision, multivision, whatever. There are 30 lens implants that are there available to be used. So lens is just an ingredient in the recipe of vision. So everything, like my cataract talk, like the pterygium, we can go through systems later, is everything from your planning to your diagnostics, how do you land at the goal of vision? If the request of the patient, having proven that they like monovision, absolutely you can do that, sure.
Okay, Dr. Gulani, so that was a wonderful session we had this evening, and it was a completely different outlook for us to treat our patients in a very higher level and to think of a happy patient. And we'll get addicted to this word of being thinking of a happy patient. And we'll be waiting for more talks by you in the near future if our lockdown extends. And thank you once again for this amazing session.
My pleasure again. Thank you so much.